morning, good afternoon, or good evening for everyone. First of all, I would like to say thank you to all of the parties so we SGD B3 could finish this paper titled Growth Plate Factor. Let me introduce myself first. My name is Chandrika Dewi with the last 3 digits student number 071. So here are the members of SGD B3. And let me start this presentation with introductions. Children and adolescents who are still in the process of growth tend to be more active in physical development due to the epiphyseal plate or growth plate resulting in the bone elongations. The growth plate, also referred to as the epiphyseal plate, constitutes the cartilaginous segments located at the extremities of elongated bones, facilitating longitudinal bone growth. However, these plates are susceptible to stress, one of which may result from the high activity levels typical of children and adolescents, leading to fracture. Epiphyseal growth plate fracture is a fracture occurring in the growth plate or physis. From an epidemiologic perspective, physeal injuries are prevalent among children, accounting for 50 to 30% of all bone injuries. While the majority of growth plate fractures typically resolve without lasting consequences, complications can occur. In rare instances, a bony breach may develop across the fracture sites, impeding bone growth or leading to an curvature. It is necessary to provide education to parents and the community so that this condition can be promptly and effectively managed. And so on, this paper is created as learning material and educational resource concerning growth plate fracture. And so this is the problem formulations using in this paper. There are the overview, the epidemiology, the risk factor, pathophysiology, types, signs and symptoms, radiological evaluations, treatment modalities, diagnosis, and differential diagnosis of growth plate fracture. And the purposes is the same as the problem formulations, and the benefit is to give a proper information and insight about the growth plate fractures. Okay, that's all for me. For the next presenter, time is yours.
My name is Komang Mahottama with the last 3 digits study number 221. Growth plate or physeal fracture may be characterized as disturbances within the cartilaginous physis of long bones that will or may not include epiphyseal or metaphyseal bone. Injuries to the physis are more likely to happen in a dynamic pediatric populace than sprains or tendons wounds are. In portion, since the tendons and joint capsules have more prominent axillary quality and astuteness than the development plates do. These ligamentous structure are 2 to 5 times more grounded than the growth plates at either conclusion of a long bone and thus are less regularly harmed in children maintaining over-the-top outside loads to the joints. Thank you.
Hello, my name is Yanti Graciella with my last 3-digit number is 162. I will explain the next part. Epiphyseal growth plate fracture is a fracture that occurs in the growth plate of epiphysis, specifically in the physis part of the bones. The growth plate is the weakest part of the bone, which is that causes frequent fractures in this area. Children are the higher risk of the growth plate fractures because in children growth plate is more weak than the tendon and ligament. Of all bone injuries, the percentage of physical injuries is quite large in range of 15% until 30%. Usually, growth plate fractures often occurs in the upper and lower limbs because in this part is quite often used. Men are more often affected because their activities is more risky compared to women. Based on the research on children aged 5 until 70 years, boys are more likely to experience traumatic injuries, while girls are more likely to experience overuse injuries. In addition, in women, growth plate mature more quickly and replace with dense bone. Most growth plate fractures happen from falling or twisting. Contact sport or fast-moving activities are common causes.
Thanks for the opportunity. My name is Sienny Kuswardi and the last 3 digits of my student number is 004. I'm going to explain the pathophysiology of growth plate fracture. There are 4 zones in the growth plate: the germinal, proliferative, hypertrophic, and calcification zones. Growth plate fractures typically happen through the zone of provisional calcification. Although depending on the injury type and the applied force, they may cross many zones. The types of injuries that may cause this fracture are direct trauma, indirect trauma, overuse or repetitive stress, and weakening of the bone structure from underlying medical conditions. The fracture causes separation of the zones in the growth plate and obstructs the normal process of bone formation. If not treated properly, this may lead to bony repair tissue formation, known as bony bar, which results in angular deformity or growth arrest. That's all from me. Thank you.
Let me introduce myself. My name is Bagus Tresna Indra Putra Pramana with the last 3-digit number 104. And now I will explain about the types of growth plate fracture based on Salter-Harris classification system. The children's bones fractures are especially referred to as Salter-Harris fractures or physeal fractures, which are defined as fractures through a growth plate orifice. It is categorized from 1 to 5. For the Salter 1 or slip type, this occurs when the fracture line goes through the growth plate or the physis. The longitudinal force that separates the epiphysis from the metaphysis through the physis is the cause of the type 1 fractures. The next, the Salter 2 or the above type. In some cases, the fracture goes through the metaphysis as well as the physis, and they most frequently happen outside of the joint space. A corner sign, also called as the Thurston-Holland fragment, is present when the metaphysis little corner is visible. The third type, or the Salter 3 or the lower fracture, extends from the physis into the epiphysis and is intra-articular, and this kind of fracture can split into 2 epiphyseal segments if it runs the whole length of the physis. The fourth type, the Salter 4 or transverse or through type, this fracture, which goes through the physis, metaphysis, and also epiphysis, is likewise the intra-articular or the previous one. Because this fracture affects the epiphysis, there might be cartilage injury. The last one, the Salter 5 type, or the rammed or ruined one, where the growth plate was crushed or compressed, resulting in this sort of fracture. The type 5 involves the transmission of stress through the physeal and also epiphysis, which may cause disruptions of the hypertrophic area and vascular supply, and also germinal matrix. And the presentation will be continued by my friend.
Hello, doctor and friends. My name is Patricia or Jotan, and the last 3 digits of my student number is 171. Now I want to explain about the sign and symptoms of growth palate injury. The symptoms often consist of the first one is persistent pain and tenderness after a sudden or overuse injury. The second one is deformity, warmth, and swelling at the end of the bone. The third one is changes in how someone bends their limbs. The fourth one is inability to move, put pressure on, or bear weight on a limb because of the pain. The fifth one, injury in children. You may notice that they self-limit the amount of time playing after a prior injury. So for the next one is the diagnosis. For diagnosis, doctor could diagnose the growth palate injury by the first one is asking about the pain and injury, including when the pain started and how the injury happened. The second one is examining, which may include checking the injured area for tenderness, swelling, or deformity. The third one is ordering x-rays. Because growth palate have not yet hardened into like a solid bone, neither the structure themselves nor injuries to them show up on x-ray. Instead, growth palate appear as gaps between the shaft of a long bone or metaphysis and at the end of the bone or epiphysis. Therefore, a growth palate injury may not be too apparent on an x-ray result. And for the next one, other doctor may also use these tests to diagnose the child growth plate injury. That includes the first one is MRI or magnetic resonance imaging, and the second one is computed tomography or CT, and the third one is ultrasound. Because these tests enable doctor to see the growth palate and areas of other soft tissue, they can help visualize the injuries and determine the type of growth of the plate injury. Okay, that's all from me. Thank you.
My name is Patricia Simpson with the last 3 digits number 1 to 5. Allow me to continue the presentation on the differential diagnosis of a growth plate fracture. So the diagnosis itself is a growth plate fracture, which is a break in the growth plate of a child or teen, and they happen mostly in the bones of the fingers, forearm, and lower leg. So the first differential diagnosis is a slipped capital femoral epiphysis, which is a common hip pathology where the femoral epiphysis is abnormally displaced to the posterior and inferior direction from the femoral head and neck. It is mostly found in pre-adolescence and adolescence and is usually idiopathic, and the patient usually presents with complaints of a traumatic hip, thigh, or knee pain. which in some cases can manifest as limping or inability to bear weight. The next differential diagnosis is little league shoulder, which is an overuse injury that is commonly present in adolescent male athletes, particularly baseball players, and is characterized by throwing-related pain over the proximal humerus. The pathophysiology of this condition is related to the cumulative rotary torque experienced by these athletes, along with the number of pitches they have thrown. The next differential diagnosis we have apophyseal fracture, which occurs in the greater trochanter and skeletally immature patients, and can be caused by indirect and direct mechanisms, but it mostly occurs due to direct trauma. Usually the patient has pain in the regional anatomy of the greater trochanter that increases with palpitation, and they might also have the difficulty or inability to walk. That's all for the differential diagnosis. Thank you for listening.
Allow me to introduce myself. My name is Yohanes with the last SGD number 089. X-rays are commonly used to diagnose growth plate fractures because they are quick, easy, and involve low radiation. However, it is often difficult to detect these fractures on X-ray because the growth plate is mainly cartilage, which doesn't show up well. This challenge is even greater in younger children whose bones are still developing. Some fractures like salted hairs types 1 and 5 can be hard to spot and might be missed. Comparing to the injured joint to the other side can help identify fractures by looking for wider gaps, tilted bones, or joints that don't fit together properly. Sometimes, if bones are out of place, the fracture is easier to see.
Hello, my name is Dewi with the last 2 digits of my student number are 146, and I'm going to explain about conservative treatment of growth plate fracture. Numerous studies have indicated that the optimal approach for treating facial fractures of distal radius and ulna in children is conservative management. This method involves the use of casting and arm's length, which have been shown to yield favorable outcomes. Even in uncommon scenarios, such as fractures involving the ulnar diaphysis or Montague type 1 equivalent fractures, conservative therapy has proven to be highly effective, leading to promising functional outcomes when managed with manual reduction and plaster cast immobilization. For an acute fracture, immediate treatment involves close reduction under suitable anesthesia. Following reduction, initial stabilization of the fracture is achieved through cast immobilization, typically for a period of 4 to 6 weeks. In cases of unstable fractures, additional measures such as close reduction with percutaneous spinning may be necessary, while fractures obstructed by interposed periosteum may require open reduction and internal fixation. Nevertheless, the involvement of the epiphysis significantly impacts treatment outcome.
Hello, doctor. Let me introduce myself. My name is Michael Jonathan Raya with 3 last digits student ID number 182. Now I'm going to explain about surgical intervention as one of the treatment modalities in growth plate fracture. So if the growth plate fractured bone is displaced, the surgeon has to set it back to the right position. This procedure is called reduction. There are 2 types of reductions, open and closed. When the displaced bone can be fixed without creating any incision or cut, it is called closed reduction. The surgeon fixes the bone with their hand, and on the other hand, when the displaced bone should be fixed by surgical interventions, it is called open reduction. The surgeon also might place surgical plates or screws for fixating the bone. After the reduction procedure is finished, the surgeon usually places a cast or splint to support the repairing bones when healing occurs. The placement of a cast or splint depends on the degree of injury, location, child's age, etc. And that's all from me. Thank you.
Hello everyone, my name is Putu and Nirajanari, and the last 3 digits of my student number are 049. I'm here about to explain the complication and long-term effect of a growth plate fracture. So the first one is the growth disturbance. So fracture can destroy the growth plate and thus disrupting bone growth at the site of injury. This can affect the continuity of growth in children and adolescents in the future, where they have the potential to grow slower than other children. Second one is the limb length discrepancy. Impaired growth due to growth plate fracture certainly affect the bone growth of children, especially in bone lengthening. This disorder can result in difference in the length of the patient's hand or maybe feet. And the last one is the premature facial closure. It is the most common complication due to visual injury or fracture on the growth plate. Growth plate that close earlier than they should can cause change in bone that should still be active to grow, could be inactive. That's all from me. The next slide will be presented by my friend. Thank you.
My name is Wildan Sifa'ul Mahsyar and my last number is 174. Conclusion. Growth plate fracture is a discontinuity in the bone occurring in the growth plate. Children are at higher risk of growth plate fracture, accounting for 15 to 30% of all bone injuries. Physical injuries or growth plate injuries are prevalent among children. Fractures in the growth plate can be caused by direct trauma, indirect trauma, overuse or repetitive stress, or weakening of the bone structure from underlying medical condition. The diagnosis of growth plate injury is made by history taking, physical examination, and imaging study. Treatment approaches for growth plate fracture are conservative management and reduction. If not treated properly, growth plate fracture can cause complications and long-term effects such as growth disturbance, limb length discrepancy, and premature visual closure.